announcements.
Okay.
Because if I don't, the person who wears her glasses on her chin will be angry. On Friday, from 1 to 5 in this room, LSC3, CBR 20th anniversary bash. So please be here. We also have the nomination deadline on July 9th for the Neil Mackenzie Award. Please remember to submit those, and remember to tell the people in your laboratories. Also, we have the CBR Graduate Award Program applications due on July 14th, and Research Day, August 9th. So please jot those down. It's my pleasure, and I'm really happy to introduce and to virtually see Heather Leitch. She did her PhD in immunology at UBC, her MD also at UBC. She did hematology fellowship at McGill, another master's in epidemiology and biostats at McGill. Then she did her post-fellowship training in lymphoma tumor group coming home to BC Cancer Agency, and is now clinical professor and division of hematology UBC and director of the hematology research at St. Paul's Hospital. And of course, she is a member of our esteemed Center for Blood Research. And I'm looking forward to hearing what you have to say about iron overload in a variety of diseases maybe today, or maybe just one important one. Thanks very much for joining us today, Heather.
Thank you very much for that introduction. So I am going to start with MDS, which is a little bit outside the kind of mandate of the CBR, being a clonal disorder. However, my real interest is in iron overload. And in order to talk to you about that, I need to give you a bit of an introduction on MDS. So let's see if I can advance my slide. Slide control privileges. Well, it looks like I can give slide control to any of you, but I can't give it to myself. There we go. Okay, so here are my disclosures. So I'm going to give you an introduction, talk about the updated MDS classification systems, new prognostic scores, MDS clear path, which I think some of you will like a lot, clonal hematopoiesis, just briefly treatments for lower risk and higher risk MDS, and then get into my real love, which is iron overload. And I wanted to not only talk to you about iron, but also illustrate how the CBR summer projects have really supported this research, then give you a summary and future directions. So myelodysplastic syndromes are a group of clonal hematopoietic stem cell disorders that are characterized by ineffective hematopoiesis and an increased risk of developing acute myeloid leukemia. So the International Prognostic Scoring System and many newer scores predict survival and AML risk with some refinement. So I thought I'd show you a few features of dysplasia. So this is a normal blood smear. That's a normal lymphocyte. The nucleus is about the size of a red blood cell. This is a not so normal, this is a normal neutrophil. Sorry about that. And so over here, you get not so normal in a slide. So you can see the red blood cells are all kinds of weird shapes. And this is a hypergranular neutrophil, which also has kind of weird lobation to its nuclei. This is a hypogranular neutrophil, which has a characteristic name. It kind of looks like a guy with big shades from the 70s. And this is called a Pelger-Hewitt cell. So people get myelodysplastic syndromes and myeloproliferative neoplasms mixed up because the classifications keep changing, which doesn't make it easier to keep track of. Basically, in myelodysplastic syndromes, the blood counts are decreased because it's ineffective hematopoiesis. The bone marrow tries hard, but because the cells are abnormal or broken down in the bone marrow, leads to cytopenias. And so the cell morphology is abnormal. In MPN, myeloproliferative neoplasm, the cell morphology is normal, but the blood counts are increased. So a little bit more morphology. This is a bone marrow aspirate. It's a normal one. So we can see a variety of cells here, and you don't have to take my word for it that they all look quite normal. This big cell is called a megakaryocyte. It's a precursor to the platelets, which of course help the blood to clot. And this is also a normal aspirate, just looked at in a little bit of a different magnification. This is essential thrombocytosis, which was one of the myeloproliferative neoplasms. So if you compare these megakaryocytes, these are great big ones. They have a lot of nuclear lobes. And so the megakaryopoiesis is quite robust. And one of the MPNs is myelofibrosis, and this is basically scarring of the bone marrow. So this is a normal bone marrow biopsy. The empty spaces here are fat cells, and you have cellularity of the hematopoietic components, basically 100 minus age. So a 20-year-old has 80% cellularity, an 80-year-old has 20% cellularity, and the rest of us are somewhere in between. This is about 40 or 50% cellular. This is just a higher magnification. So again, you can see those megakaryocytes, and then you can see that there's different cell types present. Here's ET, essential thrombocytosis, and so you can see the megakaryocytes all over the place. And there's fibrosis in the marrow biopsy. So some more dysplastic features. So we talked about hyper and hypogranulation. We're also getting weird nuclei. So this one has kind of, 3 different lobes to its nuclei. There's a red blood cell precursor. There's another one. It's called nuclear budding, and the nuclei should look more like this. And here we have, this is an iron stain, and so these are red blood cell precursors, and you have iron-forming deposits in the mitochondria, which form a ring around the nucleus, and this is what's called a ring sideroblast, in case you come across that in your reading. So, on the other hand, if we go back, so you'll see that these cells are about the same size as a red blood cell. If we go forward, this is acute myeloid leukemia blast. Look how it compares to the red blood cells. It's huge. There's lots of cytoplasm. There's lots of nuclear material. The chromatin is dispersed and open. There's open nucleoli, so it's an actively metabolizing cell. This is a stack of granules known as an hour rod. And so, these big cells can cause a lot of difficulties, including if they become elevated to a certain degree in the peripheral blood, they can, kind of clog up the small blood vessels and cause clinical problems. I'm not sure why I have a second picture of a blast there. There's particular different morphologies in the different MDSs. So again, we have a normal marrow aspirate over here. And I've tried to put this as about the same magnification. This is deletion of the long arm of chromosome Q. So this is a subtype of MDS that has a very indolent course and a favorable prognosis, low rate of AML transformation, and a long median survival. And so what these are characteristic megakaryocytes, and they're called, look at the size in comparison, micromegakaryocytes, which is kind of my favorite word in hematology. It literally means little big cells. So predisposing factors are unknown in the majority. Older age, like everything in medicine, the median age at presentation in Canada is 72 years. Male gender, and secondary to certain classes of chemotherapy and also ionizing radiation. We recognize that MDS that arises, from treatments does have a worse prognosis. So this is kind of the age-related incidence of really any hematologic malignancy. I actually borrowed this from chronic lymphocytic leukemia. And so, this is showing the increasing incidence, with age. And so here's where we were with the baby boomers, 10 years ago, and here's where we're at now. So the incidence has very much increased, but so has the prevalence, because we're getting better at keeping these patients alive. Why does the incidence decrease with age? I think it actually doesn't. I just think that, 85 and 90 and 95-year-olds have comorbidities that can limit their life expectancy. So people are more reluctant to do invasive investigations like a bone marrow biopsy. But I can tell you that I have a collection of patients in their 90s who are really very well. I have one guy who, up until the pandemic, was working out with a personal trainer 4 days per week. He's in better shape than I am. That was at age 96. So it is a serious disorder. In 84% of the low-risk patients, the cause of death is related to the MDS itself. And so it's a minority that die of other causes. And when we make treatment decisions in MDS, we take into account disease-related factors such as number of cell lines that are decreased, number of blasts in the bone marrow, and the karyotype or the chromosome analysis, which feeds into the risk scores. But patient-related factors are also important: age, comorbidities, and big one in Canada is distance from the treatment center. So one of the things that's a little bit challenging about MDS is that the classification, as I mentioned, keeps changing. So the first one we had was in the 1980s called the FAB, or French American British classification, which I think was appropriate to the era. This was pioneered by Dr. John Bennett, who is brilliant and still keeps coming to the meetings and getting up and making brilliant comments at the microphone at the age of 90. Then we had the International Prognostic Scoring System in 1997, which incorporated cytogenetics. The WHO classification came in 2001, which refined morphology. Then we had the WHO-based prognostic scoring system, which took into account transfusion dependence, the MD Anderson scoring system, because they have one of their own of everything, 2008 update date of the WHO, then the revised IPSS cytogenetic scoring system, the WHO 2016 update, the MDS CAN analysis, which I think I show you later. Then in 2022, we had two new classifications, the WHO update and also the International Consensus criteria. And so these definitions start to move into defining subtypes based on specific mutations, which I'll show you. And then we have the molecular IPSS, which incorporates somatic mutations into risk prediction, which I'll also show you. In the future, I think we're going to see microRNAs come into risk scores as well as epigenetic changes. Circular RNA is in the news. The inflammasome is important, and people are building machine learning models. So therapeutic objectives for MDS patients are to reduce red cell transfusion requirements because they do develop anemia, which becomes transfusion dependent in many of the patients, which has a terrible impact on their quality of life. So we want to improve that. In best case, extend overall survival and delay AML progression. Our ability to do this is limited and alter the disease's natural history. And so this looks like a pretty long list of treatment options for lower and higher risk MDS. But in reality, the number of treatment options we actually have access to for the majority of patients is limited to erythropoiesis-stimulating agents such as erythropoietin, supportive care, including transfusions and management of iron overload, and in higher risk patients, hypomethylating agents with or without second agents. So this is brazenly stolen from a German colleague who, kind of listed the cellular pathways that were being targeted in clinical trials in 2019. And here's 2022 and the ones that haven't worked out. So it's been a bit of a therapeutic wasteland in terms of new treatments for MDS over the past few years, but hopefully that will change in the not too distant future. But it kind of underscores how management of iron overload is important in these patients. So classification systems, I'm not going to go through the details, but this is the WHO 2017. And so one of the subtypes is MDS with ring sideroblasts, which of course I showed you, and I won't belabor the other subtypes. So here's the 2022 update. So rather than, so there's the MDS del5q, which I showed you, and so that's defined by its chromosomal abnormality. So instead of MDS with RS, we now call it MDS with the SF3B1 mutation, because the vast majority of patients with ring sideroblasts do have the SF3B1 mutation. Then there is an acknowledgement of biallelic TP53 inactivation is bad. And then we talk about number of blasts, and so that keeps changing as well. MDS with fibrosis has been recognized for a long time to be a bad prognostic factor, but this is the first time it's been brought into the classification systems. So that's the WHO, and that's the ones I wanted to point out. This is the International Consensus classification, and I won't go through the details, but similarly, they're looking at somatic mutations, chromosomal abnormalities, and they also acknowledge the TP53. There's also a definition of the MDS/MPN overlap syndromes, which I won't belabor. And so this shows the relationship between the WHO 2017, the WHO 2022, and the ICC 2022. And believe it or not, there's a second slide, so it's a little bit complicated and kind of confusing for the hematopathologists, though they're starting to get used to it. Prognostic scores. So if you look up the IPSS, which is the classic prognostic scoring system in MDS, and is still widely used because many of the clinical trials were based on IPSS score, it takes into account three things: percentage of blasts in the marrow, and you can see the scores for each, chromosome analysis, and there's categories here: good, for example, normal, Delphi Q, and so on, and number of cytopenias. So three lineages: the white blood cells, the red blood cells, and the platelets. How many of those fall below a certain range is defined, and it breaks people down as low, intermediate 1, intermediate 2, and high, or lower risk. We, put these two in the same pot, or higher risk. So this is the revised IPSS. Again, we're talking about cytogenetics, bone marrow blast percent, and then we get more detailed on which cytopenia and how low the counts are. So instead of saying just below a certain threshold, there's different categories, and there's more categories in the cytogenetic risk groups and so on. Breaks people down into 5 risk groups from very low through low, intermediate, high, and very high. Awkward because you have to divide between the middle of the intermediate group to get lower risk and higher risk. And then there's the molecular IPSS. So we've recognized that somatic mutations such as SF3B1, TP53 are very important in determining how the MDS is going to behave. And so what these investigators did is they had a discovery cohort of just under 3,000 patients, a validation cohort of 750. And this shows the different mutations that are found in MDS. You can see TET2, very common, ASXL1. Here's our SF3B1, the third most common. And what they found in their cohort was there were 48 genes mutated in greater than 1% of patients. 94% had at least one somatic mutation with a median of 4 per patient and a range 0 to 20. And so then they looked at associations between gene mutations and clinical endpoints, including leukemia-free and overall survival, as well as AML transformation, adjusted for clinical factors, and found 14, 16, and 15 genes were significantly associated with these adverse outcomes. And so this is the cytogenetic risk groups in the IPSSR, which they maintained, and looked at gene mutations as binary variables, except for the TP53 allelic state and SF3B1 co-mutations, which I'll show you in a minute, or maybe not, maybe I took that out. They adjusted for confounders and came up with this crazy looking formula, which I defy you to solve in your head, which, translated into this curve. And so then they divided it into 6 prognostic groups: the very low, moderate high, high, and very high risk groups. And this is the leukemia-free survival and overall survival. And you can see the curves nicely separate. They found that there was an increase in concordance index from the IPSSR to the IPSSM. Nearly half of patients were re-stratified, 7% by more than one strata. So this was actually published in June 2022 and has come into increasing use, and I think will be increasingly interesting in the future, particularly as people develop therapies that target specific mutations. So they have an online calculator. And so this is what it looks like. So first you put in the classic kind of factors: what are their cytopenia, what are their bone marrow blasts, and then you put in their cytogenetic risk groups, and then up come their mutations: yes, no, or not assessed. And so here's the other ones. And so they will calculate the score even if you couldn't assess that specific mutation. And that is what the IPSSM looks like. So that was first presented at the European Hematology Association meeting in June 2020. And one of the talks at the same meeting was fascinating. So this investigator who works in the US is an expert in hypermethylation in MDS, which is how the hypomethylating agents use. So methylation of the CpG groups will, of course, decrease gene transcription. I'm sure this group that I'm talking to knows that. This is at cytosines. There's the methyl group. And so what happens in a normal cell is you get a certain amount of methylation. In cancer cells, you get regions of hypermethylation, which inactivate genes, and bad stuff happens. So just to show you the mutations again, there's frequent mutations in epigenetic modifier genes, epigenetic referring to methylation of DNA and acetylation of histones and so on. And I just wanted to show you this to show you that iron is an essential cofactor in the methylation pathway. So that may be of interest in the not too distant future. So I've just listed here so that you can see them, all the pathways that are affected, which are key biological pathways. I won't read them to you, but you can appreciate they're important. And so really interesting. So this is her genome-wide analysis, and this is off my a picture off my phone, and you can see it says do not post, so don't post it. I'm not going to pretend to be able to analyze this figure, but the important thing is at MDS diagnosis and higher risk MDS, they were able to separate patients into groups. Who's going to respond to a hypomethylating agent or HMA and who's going to not respond? So how useful would that be to not have to put a patient through several cycles of therapy before, you kind of acknowledge that they're not responding to this therapy? So I think that this has huge application for the future and is something to watch. So they found that there was a, significant area under the ROC curve, and just for comparison, standard cytogenetic analysis is 0.65. This is 0.85. And when they added gene expression profiling, it increased it even further, though gene expression alone was not significant. So frequently mutated epigenetic modifier genes, methylation studies by NGS uncovered previously unrecognized hypomethylation, aberrant DNA methylation targets enhancers and distal regulatory elements at key biological pathways. Methylation captures clinically relevant information at diagnosis. Epigenetic differences can be harnessed for the development of biomarkers, and they can be further strengthened by integrating gene expression data, improving predictive performance. So here's the MDS-CAN patient registry. So this is a nationwide Canadian registry, and it was started in 2007 at the Sunnybrook in Toronto and was implemented nationally in 2012. And what it is basically a study of quality of life in MDS patients. And the patients really like this because, it's just kind of filling out questionnaires every 6 months and undergoing small tests of physical function yearly. So the 4-meter walk test, the 10 times, how fast can they stand up, sit down 10 times, how, what's their hand grip strength. And they like it because they feel like they're contributing to knowledge, which they are, but they don't feel like a guinea pig because they're not taking an investigational agent. So we prospectively collect MDS-related data, but also the frailty score, Charlson Comorbidity Index, the MDS-specific comorbidity index, and the Lawton-Brody disability score. And so we took the variables that were significant, gave them weighting, and came up with a new score. And you can see the separation in overall survival between the curves. And so this was published in 2016. But the importance of this score is it's the first and still the only prognostic score that takes into account patient-related factors. So we all know that frail patients are going to do worse, but this is the only thing that starts to quantify that. So I think in future, one of the things we'll look at is incorporating this into the IPSSM. Okay, the MDS ClearPath. So this is an online algorithm. If you just put MDS ClearPath in your browser, it'll come up. And it's to guide people through the workup, diagnosis, and management of patients with MDS. And there is a 2022 update. For those of you who are fluent in French, there's a French version as well. Access to this website. There's also an app. It's being updated. It should be available in late 2022. There's not only the overall algorithm, but a treatment wizard that leads the user through a series of questions, particular to the specific patient status, leading to a treatment recommendation. And this is maybe too much information for you guys, but I think I kept it brief. So this is my colleague, Ms. Vera Pale, he called her because she's anemic. So she referred for anemia. She's tired. She's short of breath on exertion. Her hemoglobin is 95. And for a woman, a normal hemoglobin is 115. Her mean cellular volume is 116. So normal is up to 100. So she has macrocytosis. Her cells are bigger than you would expect. She also has some other cytopenias. Her blood film shows oval macrocytes and hypogranular neutrophils, which are both dysplastic findings. We do some other stuff to rule things in and rule things out. So what further investigations? So if we go to the clear path, it says, please start here if you have yet to confirm your MDS diagnosis. From here, we can go to the overall algorithm, to the treatment wizard. There's a prognostic calculator. There's references. So then we go to, over here, we went to step one. We actually pressed on here, and this takes us to 3 steps to confirm the diagnosis of MDS, perform an initial workup for MDS. So this takes us to an information panel with links to other topics, but tells us what to do to rule things in, rule things out. Bone marrow aspirate biopsy with mandatory cytogenetics, and we've also added to send a sample for molecular testing. These are some of the common mutations in MDS. What the genes and proteins are, the frequency, what their function is, and so on, how they affect prognosis. These information panels can be closed here. So the second step is classify the patient based on the WHO classification. This is step 3, which is the prognostic scores. So all the scores I talked about before, and the comprehensive cytogenetic and the MDS frailty index. And what you can't see here in this shot, and I think it's farther to the right, is that there's a link to the IPSS-M as well. So we go back, figure out her scores, what's her IPS category. So this is the IPSS score, what it looks like, the tables. You can link to the survival rates. And then the prognostic calculator looks like this, and it's a series of drop-down menus to put in her, performance status, age, cytogenetic risk group, and so on. So we fill in some things. Her IPSSR comes up as very low risk, then IPSS intermediate 1, and as you fill in the rest, the more prognostic information comes up. That was the survival curves that I just skipped over. And then once the MDS diagnosis is confirmed, give information to patients and caregivers, do HLA typing if they're a stem cell transplant candidate. Then we click on finish. It takes us back and we can enter the treatment wizard. And I've done excerpts from this. Does she have lower risk or higher risk MDS? She has lower risk. Assessment for allogeneic stem cell transplant. This gives us information on that. Is she symptomatic? Yes, she is. Does she have symptomatic anemia, neutropenia, and thrombocytopenia? Like the majority of patients, it's anemia that's bothering her. This gives information on anemia. Does she have a del(5q)? No, she doesn't. Is she a candidate for immunosuppressive therapy? This is very intensive. I won't belabor the details, but the answer is no. And here's the treatment recommendation. So consider an erythropoiesis stimulating agent. Here's the updating less than 200 with her EPO level. So we can open up the information, and it gives us predictive factors for response to ESA, 3 different scores. I don't know what that is, so bear with me. We seem to be stuck. Here, EPO or Darbo, and what to increase over a certain period of time for lack of response. And so these are response evaluation criteria that we've included. So she wants to avoid transfusions because everyone does. And, just to belabor, if they're coming to St. Paul's, they have to drive downtown, they have to park and pay $30 for parking. They have to trip over the street people to get to the hospital. They have to have their cross match done. They have to come back the next day, do the whole thing over again, get transfused. So they don't like it. And if you can have a shot once per week, that's preferable. So she responds after we do a dose increase and maintains stable counts for 12 months. So I just wanted to show you the flags. So we have treatment information, dosing and monitoring, safety, efficacy, and reimbursement. And so if you're hooked up to the internet, which I'm not, you can click on the province of interest and it'll take you to the reimbursement page. And still I'm getting that. This is the overall algorithm, which is updated with response assessment criteria, MDS with SF3B1. We now have a treatment for that called luspatercept. We have for intermediate 1, we can use one of the new hypomethylating agents. And instead of saying an azacitidine candidate, because that's what we had, we say, are they an HMA candidate? Because they can use this one as well. So this is some of the MDS predisposing condition. And now that people are doing some testing for somatic mutations, they're finding them. Clonal hematopoiesis of indeterminate potential or age-related clonal hematopoiesis is big in the news, in the hematology news, and does predict for increased cardiovascular mortality, which is very interesting because MDS patients die mainly of cardiac causes. There's also clonal cytopenia, idiopathic cytopenia. And I can tell you from experience that, you can do a bone marrow on a patient and say, we can't find a bone marrow disorder, you're fine. And they are worried about that. But, now that we have ICUS, you can say, you have ICUS. And they're happy because it has a name and they didn't just get a bad hematologist. So clonal progression in myeloid disorders. So we've got our stem cells and we get mutations in epigenetic modifier genes such as TAT2, which we saw before. This leads to clonal hematopoiesis, and then you get increased self-renewal from, changes in splicing factors and transcription factors, and subclones are selected for, and, you get inhibition of differentiation, which leads to higher risk MDS and AML. So I think this is an unfolding story and is very interesting. And so I will stop talking about clonal stuff soon. This is the most recent EHA, where this guy, suggested that oligoclonality emerges at considerably younger age when selective advantages are there, including organ-specific driver mutations, disease, lifestyle, medications, germline variations, and the bone marrow microenvironment and the methylation profile. So I think this is quite fascinating. And this has led a group in Israel to be able to predict acute myeloid leukemia development in healthy individuals up to several years before they actually develop this disorder, which is great. Maybe not so nice to know that in X number of years from now, you're going to have acute leukemia, but it raises the possibility of actually intervening to prevent that leukemia development. So they had more mutations per sample, higher VAF, greater clonal expansion, showed enrichment of mutations in specific genes. And this is the prevalence of somatic mutations with a VAF more than 10% by age. You can see it very much increases with age in the pre-AML population compared to the control. And this is the ROC curve for predicting AML, which has a sensitivity of 94.5%, which is very high. And then this is some of the somatic mutations. They showed an interest in SRSF2, which you can see has a big separation between the curves and also a lot of, notches on the curve. So treatment for lower risk and higher risk, very limited, as I showed you. We do have a clinical trial of an erythrocyte pyruvate kinase activator to try to protect the cells from breakdown. At St. Paul's, there was a trial in higher risk at Surrey. There's now a second-line therapy for higher risk MDS, which has been a real therapeutic vacuum. And hopefully we'll have oral azacitidine coming to soon. Currently, it's given by subcutaneous injection 7 days out of 28 days. Iron overload. So this is my thing. So it is discussed in limited detail in the MDS Clear Path. But we have this message that the MDS iron road, you can go outside the clear path and get to that algorithm. So just to back up, transfusion dependence and lower risk MDS is associated with inferior overall survival. This is from the Italian group. This is back in 2005. So this is receiving 0 units of red blood cells per 4 weeks, then 1, 2, 3, 4 stepwise decrease in survival with a decrease in leukemia-free survival as well. More recently, from the European Leukemia MDS Registry, no transfusions, low transfusion dose, high transfusion dose, stepwise decrease in survival. So these are the Canadian guidelines that I wrote in 2018 that were published in Leukemia Research for the management of iron overload and MDS. From that, we made an online algorithm called the MDS Iron Road, again in English and French. I don't know if you can appreciate it, but this is actually a train engine. So for 2 reasons. The first is the word for iron for railroad in Italian is ferrovia, which is literally iron road. But more importantly, the song from Gordon Lightfoot, which some of you in the audience are old enough to know who that is, the Canadian Railroad trilogy. They look in the future, and when they saw an iron road running from the sea to the sea. So this is Lord Strathcona driving the last spike in the Trans-Canadian Railroad at Craigielachi, BC, which is just outside of Revelstoke. And this, I didn't realize until I was doing this, was a big part of the deal that brought BC into Canadian Federation. So it's kind of a Canadian moment. This is the overall algorithm. Lower risk MDS information on what that means. Higher risk information assessed for allogeneic stem cell transplant eligibility. Do they have transfusion dependent anemia information? Do they have a reasonable life expectancy? Do they have documented iron overload information? If not, monitor iron status information on how to do that. If yes, reduce iron overload, preferably by inducing transfusion independence with MDS treatments. This talks about details of iron overload and transfusion in the usual clinical setting and in the stem cell transplant setting. If you're able to induce transfusion dependence, you can do phlebotomy, information on how to do that. If not, chelation with information on that. We have levels of evidence and grades of recommendation, future directions, and references. So like the MDS ClearPath, which has the treatment wizard, we have a step-by-step series of questions that is called the IR Express. And this is an excerpt. Are they eligible for therapies that induce transfusion independence? If you say yes, it takes you outside the algorithm to the MDS ClearPath to discuss those therapies. If you say no, it takes you to information on chelation. If you say received a therapy that can induce transfusion independence, it takes you to information on phlebotomy. So, randomized controlled trials. There's only been one, the Telesto trial, randomizing patients between the oral chelator, deferoxarox, and placebo. It had problems. So first of all, the study population was reduced by 2/3 because of slow enrollment. Secondly, the mean age of diagnosis of the MDS patients was only 60, which is considerably younger than our 72, which we would expect. And thirdly, half of the placebo group dropped out and subsequently received chelation. So lots of reasons for it not to show anything. But in fact, there was a split between the curves and event-free survival, which I think is actually kind of impressive. But it has been controversial in MDS, and so some people don't believe that iron overload is important. We turn to the Canadian MDS Registry, and you remember that we actually prospectively collect data on patient quality of life. So we can look at that data and see who's what. One of the criticisms of retrospective analyses that suggested better survival in MDS patients was that you're choosing the better MDS patients to receive iron chelation. Well, in fact, between the groups, they were not different according to those 4 scores that I showed you. And you can see that in all patients, those who received chelation did better than those who didn't. And now this is a matched pair analysis, matching patients for age, IPSS-R score, number of units received per month, and time from MDS diagnosis until transfusion dependence. And still you see a difference between the survival curves. And I should say also that the survival was measured from time of transfusion dependence. So avoiding lead time bias, when you're looking at retrospective analyses, you can only measure from MDS diagnosis. So what's going on? So first of all, lumps depositing in the tissues and organs of iron are not good. But in addition, this is our normal transferrin saturation. Once you saturate it, you get the appearance of non-transferrin bound iron, which has a redox active subset called labeled plasma iron. And LPI can permeate into the tissues and organs, including the bone marrow, but also because of phantom chemistry and its ability to transfer electrons can form reactive oxygen species or oxygen-free radicals, or ROS. And these have been shown in multiple preclinical studies to damage lipids, proteins, and nucleic acids. So I'm sure you can appreciate that that can have consequences for the cells. So clinical data from the EU MDS registry, the best survival was in patients who did not need transfusions and had undetectable labeled plasma iron. Worst survival, transfusion dependent, had detectable LPI, and intermediate survival in the other two groups. In the stem cell transplant setting, worse overall survival by pre-transplant liver iron concentration, which is not surprising, but also by pre-transplant LPI. And what's going on here? So this is one of the CBR projects. This was the 2020 project. It was virtual because of obvious reasons. And so in the hematopoietic stem cell, what's happening is this. Usually you get uptake of iron bound to transferrin. It's released in the endosome, and then the iron goes into the label iron cellular pool. But you can also have unregulated uptake of non-transferrin bound iron, which expands the label iron pool. We get the formation of ROS. This can affect energy metabolism, shift the cell to oxidative phosphorylation, which causes it to exit the quiescent state and undergo cell senescence and exhaustion and death. You also get loss of more than half of full-length mitochondrial DNA because it doesn't have histones to protect it. That further affects cellular respiration. You activate caspases, and you get oxidative DNA damage, which results in basic signal repair, double-strand breaks, non-homologous end joining, which is error-prone, again leading to G2M arrest and also leading to AML progression. You get peroxidation of lipids, which are long-lived, which can oxidize other macromolecules, more lipids, proteins, nucleic acids. This can lead to cell and organelle lysis, alteration of the fluidity of membranes and channels, and you get a shift in myelopoiesis away from CFU mega erythroid to CFU granulocyte macrophage. And so we didn't have enough room on one figure. So here's the other things that it does. So we talked about energy metabolism. HIF-1 alpha is degraded through the proteasome, which also has effects on quiescence and death. Fragments of mitochondrial DNA move to the cytosol, where they activate the NLPR3 inflammasome, which is thought to be responsible for some of the key features of MDS, such as impaired hematopoiesis. We have effects on the VEGF promoter, which has effects on quiescence. The TNF receptor contributes to ROS. This decreases phosphatase activity, which is a widespread effect leading to increased kinase signaling, altered cell signaling. I-kappa B is altered and leads to alterations in NF-kappa B, altered proteasomal degradation. And finally, we have impaired DNA binding. We have differences in the expression of cell surface receptors, so that alters their ability to interact with their co-receptors on the cells of the bone marrow microenvironment. So all of this has effects on cell growth. So I told you that cardiac disease is the leading cause of non-leukemic death in MDS. So MDS and AML are the leading cause, and then the next biggest slice of the pie is cardiac causes. There have been epidemiologic studies showing that transfusion-dependent patients have higher incidence of cardiac events. This is another CBR project. Colleen Wong in 2018 actually showed that there was a shorter time to first cardiac event in those in our patients not receiving iron chelation therapy compared to those receiving chelation therapy. What's going on in the cardiomyocyte? A lot of the same stuff, but key differences are that there are three NTBI receptors that take up NTBI in an unregulated manner. And also, you remember we get damage to proteins. Well, first of all, cardiomyocytes are very mitochondria rich because we need that for contraction, but also they damage the myofibrils. And so this could, of course, lead to an increased incidence of clinical cardiac events in MDS. So this is an electron micrograph from a normal cardiomyocyte, and I don't need to walk this audience through that. Everything looks, nice and organized. And so here's an electron micrograph of cardiomyocyte from beta thal major with cardiac iron overload. And, the myofibrils is basically completely disappeared. The mitochondria are blasted apart, the nucleus is, and I'm sure you can appreciate which you would prefer your heart cells to look like. So this resulted in a publication in Critical Reviews in Oncology Hematology. Cecilia Kim was the first author. And so, labeled plasma iron, NTBI, those are all readily measured using FACS analysis. However, it's difficult to apply these in a clinical lab. We do know that at a transfer saturation over 80%, we get the appearance of labeled plasma iron. So we went back to the Canadian MDS registry and looked at transfer saturation. 718 patients. Sure enough, those with a TSAT over 80% had inferior overall survival, but also inferior cardiac death-free survival, which goes along with what I just showed you about blowing cardiomyocytes apart. This is an abstract from a recent ASH suggesting that we can inhibit the uptake of non-transferrin bound iron using calcium channel blockers, such as amlodipine, which is in widespread clinical use. So that will be very interesting to know in the future. Other CBR summer student projects. So we talked about Cecilia Kim. Colleen Wong did the iron overload and cardiac toxicity, also iron overload in AML. Shannon Wong, yes, they're sisters, did iron overload and infections in MDS, and similar to the cardiac one, the ones that did not have chelation had a shorter time to first infection. She also did a project on screening for PNH in MDS. Brad Williamson looked at autoimmune manifestations in MDS, which occur in up to 30% of patients. He also looked at MDS in HIV patients. Harpreet Kochar looked at durable transfusion independence in MDS with iron chelation. Erica Sang looked at reduction in ferritin with response to ESA in MDS and also to azacitidine. And so there's the infections analysis that I showed you. So shorter time to first infection, even though there was a similar number of infections between groups and similar severity. This is Erica Sang. So these are the ESA non-responders, pre-ESA ferritin, post-ESA, a big increase. ESA responders is a smaller increase, and then azacitidine, you can see a huge increase in ferritin in the non-responders with virtually no change in the responders. This is Brad's clinical course of our patient with HIV and higher risk MDS. It's the first patient reported in the literature who actually got a specific treatment. And this is the autoimmune manifestations in MDS, which I won't belabor, but can be multiple. This is also a cartoon that Brad put together about what's going on in terms of T regulatory cells, cytokines, gamma delta cells, and how different treatments influence this pathway. And this is the durable transfusion independence that Harpreet Kochar wrote up. So as one of my final words, we need better chelators. The chelators we have are often limited by toxicity, primarily renal toxicity. Your brilliant Dr. J in the CBR has linked deferoxamine, one of the chelators, to HPGs and show decreased toxicity and also much longer half-life. So instead of doing continuous subcutaneous infusions because of a short half-life, you can actually do subcutaneous boluses twice per week. So that's just showing what I just said. And ART also is working on organ targeted chelators targeted towards the liver and also the heart. So finally, this is what I'm currently working on. So mutations, as I told you, are important. This is where they influence, kind of MDS progression and pathophysiology. And we're looking at what's in the literature about an interaction of iron overload and oxidative stress with specific somatic mutations. And that's in progress right now. So I wanted to show you what the internet is saying. So iron is the new cholesterol is the name of one article. Talks about how iron is central to many processes and disorders. This is an abbreviated quote, such as the Faustian bargain that's been struck by life on this planet. Oxygen and iron are essential for energy production, but may also conspire to destroy the delicate order of our cells. Life was designed to exist at the very interface between sufficiency and deficiency. Even more fascinating, iron is needed to the signaling molecule. It's not really a molecule, it's an atom. But it talks about how iron was involved in signaling billions of years before the existence of ATP, which of course we're used to thinking about as the energy source in the cell. Environmental conditions and porous hydrothermal events where heated mineral-laden seawater spews from cracks in the ocean crust created a gradient and positively charged protons that serve as a battery to fuel the creation of organic molecules and protocells. So here's heated mineral-laden water spewing and setting up a gradient. And so without iron to form that gradient, we might not have life on this planet. So how cool is that? So I borrowed this from the Thalassemia International Federation, Keep Calm and Chelate. And I would say keep calm and reduce transfusion requirements. To summarize, significant advances that made the understanding of MDS cellular biology, leading to new classification systems. For several years, these advances have not translated into a lot of new treatments. Incorporation of mutations into the IPSSM have refined prognosis. Further refinements are expected with future advances. The MDS clear path has been updated to reflect progress in MDS. The MDS iron road is now available for management of iron overload, and the CBR has supported several student analyses that have moved forward our understanding of iron overload in MDS and the students' careers. And so I just wanted to point out that we're an International MDS Foundation Center of Excellence and have been for several years. And also there's been a newly formed BC Cancer Agency myeloid tumor group. The head is Dr. Linda Foltz, who's in the office next to me. We have regular meetings, regular myeloid conferences. We plan to set up a myeloid tumor database. And we just completed our first myeloid fellowship, Dr. Wendy Davis, who's now on staff with us at St. Paul's. And we would like to do future myeloid fellowships as well. Almost finally, we've been invited to submit a bid to host the International Symposium on MDS in 2027. It's held every 2 years, usually in Europe. So keep your eyes open for that. And the last thing, which I don't think I have a slide on, is that I am currently right now, and this is kind of hot off the presses, writing a how I treat iron overload in MDS article for the journal Blood, which is kind of a big deal. So our 2023 summer student project, Rayan Ramadan, is looking at idiopathic autoimmune cytopenias and comparing them to the cytopenias in CLL. So that's obviously quite different from what I've spent most of my time talking about, but, is also equally interesting. So I know I haven't left a lot of time for questions. That's my email address. Happy to take this up later. And I will be there for at least part of the afternoon on Friday. So you can certainly talk to me there as well. That is my fast walk through MDS and iron.
Thank you very much, Heather. That was great. Wow. I'm sure we've got some questions in the audience. Anyone?
I have a question. If I'm zoomed in right now, everybody can hear me, right? Yeah, Heather, I just wondered your opinion on the variant allele frequency. You've already touched on this in your talk, and obviously the higher usually the worse, but in terms of using it for diagnostic purposes, for example, a VAF of 1 or 2%, do you consider that to be significant enough?
Honestly, Ben, I think we don't really understand that well enough yet. And so I kind of rely on the reports from the molecular lab. And I think that this is, a situation that will become increasingly clear kind of as we move forward. There were a number of very interesting presentations at the most recent EHA where they talked about somatic mutations and CHIP and what have you, but I don't think they're there yet. So at the EHA, I kind of focused this year on the preclinical and translational presentations, and that's where they were discussing this kind of issue. And I have to say, and I should have said up front, that it's really so nice to be, to talk to an audience that can appreciate that, and obviously clinicians can as well, that are more focused on the clinical evidence. Yeah. Hey, Shani, how are you?
Hello, thank you very much for the amazing talk. I look forward to reading your How I Treat article very much. Just a quick question about how to manage iron overload in MDS patients. Obviously, we can't do phlebotomy to get rid of the iron excess. And many patients often refuse to have the desferrioxamine because they don't want to have the infusion, and obviously the ferriprone can cause cytopenias, and I think there's a lot of difficulties in getting access to agents. Do you have any pearls of wisdom for that?
Yeah, it's just, it's tricky. So you're absolutely right. People don't like deferoxamine for obvious reasons, but a lot of them can't tolerate deferoxarox also for obvious reasons. Deferriprone, as you say, we are worried about, agranulocytosis because it does have an incidence. Is that incidence higher in people with, acquired anemias? I don't think we know that for sure. There was a registry analysis presented at ASH, maybe last one or the one before that, by Dr. Amber Ziden from the East Coast in the US, who did show that the safety was actually pretty good. There were 4 patients out of, I'm going to say maybe 37 that did develop neutropenia. They discontinued the medication, and 3 of those reversed, and 1 was ongoing, kind of at the last follow-up. But I guess what I would say is if you do have patients that you're having, kind of trickiness with, do feel free to email me or call me or just refer the patient. I'd be happy to review them. One thing that I will say up front, this is off-label use, and so take it with a great big caveat, is eltrombopag has very strong iron chelating activity. And in animal models, John Porter's student actually showed that used at low doses, it synergizes powerfully with some of the other chelators. So that might be an avenue for the future. I'm not sure that that's going to come into clinical trials anytime soon because the manufacturer's, patent has expired. So unless a cooperative group looks at that, I think in a clinical setting, we won't have clinical trials anytime soon. But that's one of the things I keep in the back of my head and sometimes use in patients who can access it, which is a minority.
Heather, we have a question from our audience, Cedric Carter.
It's the same theme. The sort of holy grail has been better chelators. Is there like on the, desferrioxamine is around when I was a medical student, has all the problems you're well aware of. Surely there must be some other way of getting iron out.
Yeah, right. How are you? Nice to see you. So there is a new chelator that's coming from a manufacturer in Denmark. It is oral. It's taken every second day. They are currently planning a clinical trial. It's going to be a non-inferiority trial comparing deferoxarox to this new chelator. So there's that. I personally really like Jay's chelator, but I think, where that's at in clinical development, maybe I can get an update from him on Friday when I corner him and pick his brain.
Do we have more questions? Yep, go ahead, Rainey.
Sorry, can't hear.
Okay, just a quick question. Did you at all look into the hepcidin, hemojuvelin, or matriptase 2 concentrations in your MDS patient? Because as it's a major regulator of iron overload, and I think proteases should have more focus in your research.
So I think it's a great question. So, hepcidin, no, I have not looked into that myself because I don't have access to hepcidin assays, but other investigators have. And back in the older classification, Valeria Santini from Florence showed a few years ago that the patients with the lowest hepcidin levels are refractory anemia and RARS. And so as the clinicians in the group know, we can have RARS patients who present with high ferritin levels without even having had a transfusion. And the reason for that is hepcidin levels are low, and so ferroportin allows iron to be absorbed through the GI tract. And so certainly there is, kind of interest in manipulating the hepcidin sort of ferroportin pathways, but the main source of iron overload in the majority of MDS patients is red cell transfusions. So I think that, until we have better chelators, we just really need better medications to decrease transfusion requirements and eliminate transfusion requirements in MDS patients. The only thing that can actually cure the MDS, of course, is an allogeneic stem cell transplant, but that is available to only a minority of patients because of age and comorbidities and, donor situation and, very technical reasons, which obviously the transplanters can address better than I can. I do think it's something that's going to be very interesting in the future once we do have medications that will actually, decrease the transfusion requirements. But right now, what we have to do is get rid of the transfusional iron.
Thank you very much, Heather. We're at the top of the hour, and we all have benefited from your educating us. We'll see you in a couple of days.
Okay.
Bye-bye. Thanks again.
See you later. Bye.